Patella instability is actually a spectrum. It's a problem that can be as simple as person just feeling sense of apprehension that his kneecap might not be in right place. That is one spectrum end, ranging to the other end, where actually the kneecap is out of the place, is dislocated. And there's something in between where the kneecap subluxate, meaning it moves excessively outwards or lateralwards. And the whole spectrum of this actually is a complex issue because there are associated factors that need to be considered in terms of patient's hypermobility, patient's limb or lower limb, in this case, rotational profile. Is this something which has happened after a trauma? Is this something that patient has had all along their life, which is usually hyperlaxity? Is this something that patient can do themselves, which is called habitual? Or is this something that only happens after trauma? Or is this something that can happen in, for example, sleep? So it's a big spectrum of a problem. It's a relatively common condition. And usually it affects teenagers and young people. Now, these are X-rays of different types of patella. The one where I'm pointing now on the left, this is a patella and this is femur. So you can see the articulation of the femur and the articulation of the patella, they match, they're synchronous. While on the other spectrum, you see this is femur and this is patella. Now, this is shape of one patella and this is shape of another patella. So here the problem is the shape of the patella, which is called patella morphology. Okay. The next slide that I'm going to share now. Here, the problem is the shape of the femur. Your patella might be correct shape, but this is the part of the femur where the patella engages, the kneecap engages. You see, this is a normal looking shape. Here, this is called trochlea. Here it is flat, and here it's opposite. Another slide. Here, you might have normal shape of both patella and trochlea, but sometimes the patella just doesn't sit where it should sit, meaning this is a normal patella position. And here, the patella sits way high up. It's called patella alta. So once we see these patients in clinic, we assess them, we examine them, we do some basic investigations, usually start with plain X-rays and then CT scans and MRI scans based on individual case and check their bony morphology and then decide what treatment they need. And this is a complex problem because here you need to identify the individual patient's problem. For example, half of my practice is hip and knee replacement. And to an extent, when we see arthritic hip or arthritic knee, you replace their joint. And essentially, it's a comparable operation to all of them. All the patients with hip replacement have all the patients with hip arthritis have hip replacement. All the patients with knee replacement have knee replacements. And all the knee replacements are similar. They're comparable. Yes, the implants, designs, and shapes and size are slightly different, but at the end of the day, it is a knee replacement or a hip replacement. While this is a complex problem because there is no one operation that fits everybody. You need to assess individual patient's problem. Is there ligament torn? In which case you can just reconstruct their ligament. So let me share this screen with you. This is a case of MPFL rupture. This is MPFL stands for medial patellofemoral ligament. It's like a check rein that's on the inside of the knee and that avoids the kneecap dislocating on the outside. Now, this red area here represents this is torn or injured here in the middle. It can come off from its kneecap attachment or from its femur attachment. Now, this is the simplest operation for the treatment, for all the operations that are available for this treatment. So here, we can reconstruct this with a hamstring tendon, and this is called MPFL reconstruction. Now, this operation will only work if rest of the morphology is actually reasonable. I'll give you another example. So this is another case where the kneecap is actually sitting high, like we saw in the previous slide. It's called patella alta. Now here, if you just reconstruct the ligament, that might not work. So then we have to augment that kneecap reconstruction ligament with something called tibial tubercle osteotomy, meaning we make a cut here and we move this bone down and then fix it with screws. So what that does is you can see the kneecap is here, while after the operation, the kneecap now sits down. Okay, so that these are the things that make this operation, or rather this condition, complex, because you need to understand which patient needs what operation and cater accordingly. You cannot do same operation for every patient. So the rehabilitation also varies based on how much surgery the patient has had. If the patient just have had MPFL reconstruction, then usually it's a day procedure. It's done in my practice in the morning, and then they go home same day in the evening. They're allowed to put weight on that. I do use brace for a couple of weeks just to protect, but that does allow them to bend fully. But at the same time, if the operation involves osteotomy, meaning along with the ligament reconstruction, we have to osteotomy, meaning breaking a bone and repositioning it. Sometimes we just pull the tendon down or the patella down. Sometimes we change the position to more medial side. Then that is a much bigger surgery, and it is much painful operation to recover from. That then basically takes about 3 months for them to go back to good level of mobility and function, and a lot of rehabilitation and physiotherapy. Uh, the long-term outcome, again, depends on the complexity of the case. Now, this is a relatively common condition. And a lot of time, in fact, the majority of times, if it's just a traumatic event that has caused one instability or dislocation, then we send them for rehabilitation. And that goes on up to 6 to 9 months. Only if the rehabilitation does not help, or the problem remains recurrent, meaning the kneecap keeps dislocating frequently, only then we start offering operations. And again, based on individuals' bony abnormality and morphology, the operations vary. Um, Overall, the results are good, but when we do the entire operation of osteotomy and mobilizing parts of the bone, then you have to understand that the forces that go through kneecap change. So yes, the kneecap becomes stable, they don't dislocate, but again, it depends on what is the expectation of the patient. Is the person looking at going back to sport? Is the person just looking at having a kneecap that is stable now, does not dislocate? And based on how much surgery is involved.